Leonidas Quintana was scheduled to be here, but he had a family health emergency and canceled. But this goes back to the earthquakes in Chile and Haiti in 2010, and Leo and I were talking, how are you going to have a better outcome? And it looked like the system itself sees a major renovation. We can't just keep pouring money into the same structure. And I'm glad that the progress in global neurosurgery has been great. I think we have to expand that to surgery and the healthcare field in toto. As you can see here, the people who are involved in this, and this expanding group of people, are fairly eclectic. Tariq is, when I came in 2009 the first time, I was impressed with when he started Northwest, and it's just been amazing what you've done since then with the prevention that started, 20 years ago. So he has a concept of this integrated response to healthcare needs that a lot of people don't. They'll build a white elephant and it's kind of not part of the whole system. But as you can see there, in addition to Tariq from Pakistan, Lubna Samad, who I guess also was supposed to be here, was unable to make it. She's a pediatric surgeon, I think, in Karachi, who's involved in some of the global surgery efforts, and the Pakistan INSO, and also Rashid Juma. Some of the other people there, Sergio Aguilera is a neurosurgeon in Chile. So he and Leonidas Quintana have been working on a similar project in Chile. Roxana Garcia is working with Patricia Garcia, who's a former Minister of Health for Peru, on various health issues, particularly regarding women. But she also is interested in this, advancing neurosurgery in developing countries. Rafat Latifi, I think, is giving a video. So he's a pretty amazing fellow as far as telemedicine and developing programs for developing countries to maximize resources. Key Park. Robert Dempsey is the chairman at the University of Washington, and really quite knowledgeable about this twinning concept of taking institutions in developed countries and matching them to underdeveloped countries that want to work together. I think the crucial aspect is this two-way street of information flow. Jeffrey Rosenfeld is a major general in the Australian Army, and also one of the world's experts on bringing the military and civilian resources together. Corey Skurlock, who I was hoping might make it here, is a pretty impressive information technology fellow working with Rafat Latifi. Rafat Latifi is a chair of surgery at New York Medical College, and Corey has developed this. They gather information that's just amazing on every patient that comes through the hospital. And he has an interest in, I don't want to say dumbing it down, making it simpler, and then it can be transported around the world so you can get sort of a common database. Nigel Crisp, it's actually Lord Crisp. He was the head of the National Health Service in the UK about 15 years ago. And since he's retired, he's been interested in how we can deliver cost-effective health care from looking at what's going on, particularly in sub-Saharan Africa, but also in Pakistan. And he's head of, or he's a co-chair of Nursing Now, which is a global nursing effort. I think we have to realize that over 50% of the healthcare delivery is from nurses, and unless we include those people in our development plans, we're really not doing a good job. Haitham Shoman is, he's actually originally from Egypt, but he's part of the Harvard program and particularly dedicated to the Pakistani NSOP and National Surgical Vision for 2025. Luke Cadell is also on the Harvard program. Montre Smith is a nurse interested in disaster management at the University of Louisville, and Laura Lippa, another person very interested in disaster response. So this is just their various affiliations. Kind of look like a medical presentation. I'm going to give you two events, or like two case studies. This is what got us started. Event number one, some data. 2004 and 2008, there were over 200,000 deaths from natural disasters. 2008 was largely due to the earthquakes here in Pakistan. In 2010, about half of those 300,000 deaths were due to the Haiti earthquake. Well, it was estimated that in the Haiti earthquake, 20,000 people died who could have been saved if there'd been basic surgical resources to set fractures, blunt trauma, and not too severe head trauma. That's a huge number of people that could have been saved over the first 3 or 4 days. The problem is there's nobody there to do that. The first group that got there, the only group that got within 24 hours with any surgical resources, was the Icelandic search and rescue team. I guess in Iceland, they got this group that can go. And there's a couple other ones in Belgium. They're similarly set up. But again, there's no clearinghouse for having this happen immediately. So it's rare. They really have to get the invitation from the health ministry in whatever country is affected before they can dive in. Well, this is the bureaucracy for the Haiti earthquake response. Just within the UN disaster response, it's again a huge bureaucracy, and it is days or weeks before somebody's actually there to deliver medical care. On the right side, you see the WHO timeline, and it's better part of a week before they expect anybody to be delivering actual health care. So that obviously doesn't cut it in neurosurgery. So that was kind of what got Leo Quintana interested. Another event was stateside. These are the statistics. There are about 850 medevac helicopters on the civilian side in the US. The military is probably about the same, maybe a little more, most of them in the Army. And you don't have to read through this, but this is just showing it's really a fragmented system on the civilian side. Some are hospital-owned helicopters, some are operator-owned, the government operates some of them. But I don't usually bring my family into things, but that's our younger daughter on the extreme left there. She's flown a number of times in F-16. She's an aerospace physiologist, but the main reason it's got a segue into the bottom right is her husband's an Air Force pilot, and they were stationed a few years ago in Montana, and he was on, his team was on call for emergency responses 24/7, and I'm familiar with that. I was an Army flight surgeon many years ago, and we did a lot of training runs. We could have been doing real saving people. And so I give you this hypothetical situation. You're ready to go, and you're in Montana, and you get this call, there's been a traffic accident. What's your first response? Do you hop in the helicopter and go out and rescue them? No. In the US, they have to, by law, call around to make sure there's no civilian helicopter that could rescue them, because that's how they make money. This is very typical of US healthcare. So I spend a lot of time when I'm in international meetings telling people, learn from our example, but don't do what they're doing in the US. It's not what medicine's all about. And this is just you can see the underlined at the bottom there, civil authorities are responsible for evacuation within their jurisdiction. And that's basically to protect the civilian financial resource. If they can fly a civilian helicopter, that's how the hospitals make money, or whoever owns a helicopter. Well, you're all familiar with this sustainable development goals, and number 3 is the healthcare goal, but a lot of these are intertwined. If you improve healthcare, you improve education, reduce poverty, etc. Just some statistics. Some of this you'll be familiar with, but I don't think people have put in all these slides. You can see for low-income countries on the far left, natural disasters are a major cause of injury deaths. Traffic accidents are probably a problem everywhere. And you can see the numbers there, 2 million lives are lost a year from injuries. And the cost of natural disasters is close to $500 billion. And if we don't address this, we're going to be losing trillions over the next decade. So we also know that 1/3 of all deaths presently in the world are due to lack of surgery. The Lancet Commission really changed, Leo and I would talk about this, and well, there's very little interest on the neurosurgery side because it's not neurosurgery, it's something bigger than that. But other groups was, oh yes, it's interesting, but again, the whole concept of integrating mass casualty response into the ongoing system was pretty foreign to most people. They usually think of the Red Cross coming in, or like the cavalry, Red Cross, the UN, or Médecins Sans Frontières, coming in a week later and saving everybody. Well, most of them are dead by then. But this Global Surgery 2030 made it clear, hey, if you have surgical capabilities 24/7, it's going to make a huge economic difference. And the penalties of not doing this are immense. And it's hit the lay press in the US the last few years. And Walt Johnson, I think, is a very interesting quote. It would cost $420 billion over 15 years to bring the lowest income countries up to the middle income countries standard for healthcare. But if you don't do that, it's going to cost you over 20 times more. So it's not a cost, it's an investment, I guess. So it's a good thing to keep in mind. And not everything, it's like maintenance on your car, not everything is something that you're saving money by spending the least at the same time. And this has been recognized now, I think this quote, time for revolution. And I think that's what our view is. The present system is malfunctional. We need to think of new ways of doing things, but learn from what we've found that works. And here's just showing you that, again, the costs from these conditions that are basically surgical conditions, where cerebrovascular disease, neonatal death, traffic accidents, and cancer. And this is just a publication. Luke Cadell was one of the authors, showing the parallel between surgical and disaster planning. And that's exactly what we've found. And we've got to bring those two things together. We're going to make a lot more headway than if we try to look at those separately. So you have both natural and what we call unnatural disasters or man-made disasters. Terrorism, that's just a map on the bottom right of some of the terrorist events in Europe. So why has this been a problem with mass casualties? It's no single person or group's responsibility, and they're not ready for immediate deployment. And so that's why we need to find a system that is ready for immediate deployment that can take care of those sort of situations. And well, the World Health Organization recognized years ago, you really can't bring in the cavalry from outside, the Red Cross or the UN. You've got to have those resources within the country itself. And that's where it was very gratifying to see what's available here with the military yesterday. They're really working quite nicely with the civilian sector to maximize their benefit from the resources they have. Excuse me. There is one benefit to mass casualties. There's that humanitarian effect. We saw this in Haiti. We see it in every large disaster. It brings people together who might normally not even talk to each other because of the humanitarian aspect of dealing with a mass casualty. So how do we deal with that? Leo and I thought that, well, what's worked so well in the developed countries, the trauma stroke center model, where you fully integrate not just the response to trauma, but you have prevention programs, which we've heard about, the acute pre-hospital transport, acute and intensive care, rehabilitation, and also it affects medical education and training and basically certification. These are all goals, say in neurosurgery, kind of working towards universal certification of neurosurgeons. I mean, that's a long-term goal, but you got to start somewhere. And stroke and trauma centers are a good model to build off of. And this is just showing an example of 30% increase in mortality. And this was in the US. If you went to a non-trauma center or in a trauma center, you're 30% more likely to die in the first 48 hours. A nationwide study in Finland on strokes. And if you went on the left is a comprehensive stroke center versus a general hospital. Again, you're much more likely to be dead at a year and less likely to be living at home independently if you go general hospital. So the evidence is pretty much there that this stroke trauma center model works quite well. And so what we proposed was, well, let's expand this, look at the things that are weak in that model and how can it be expanded to deal with. There's really no difference between 2 or 3 people being injured in a car accident and 100 people being injured in a train accident. It's just a question of scale. But the other factor is many things such as earthquakes may destroy your infrastructure. We'll talk about that in a talk this afternoon. But these are some of the characteristics we're looking at. Not necessarily helicopter, a lot of places, and ground ambulance is fine. But anyway, being able to get to that disaster site within 12 to 24 hours, and hopefully less than that. It's got to be fully integrated, and preferably an underserved region, but even in the US, there are plenty of underserved regions. Probably Venezuela or Syria are not the sort of places you'd try to start one of these programs right now. A stable government is a prerequisite, or you're just wasting a lot of energy. And this whole concept of twinning or the relationship between academic centers or medical centers in developed countries and underdeveloped countries seems to be pretty successful, and it's pretty hard to implement something like a trauma center in places, say in Africa or maybe even here, where there may not be the background to bring all that together at once. And so the real benefit, though, as I mentioned at the bottom there, it augments the healthcare resources of the region 24/7, 365. That's economically the big benefit. You're going to sell this to a health minister. That's what they're going to listen to. They're not going to listen to, gee, you have this earthquake every 10 years, and you can save these lives. We have this center, and the minister's looking at it and saying, gee, you know, I'm going to spend this much more time, effort, and money day to day just for something that happens every 6 or 8 years. But if you show every day, you're going to save money because less people have become disabled or die. Let me run through this. This just shows, again, some of the benefits. And I guess since our time is short, we'll, oh, I thought the bell rang, but you can read through that. Things like having a research platform. If you have a number of these centers around the world and they have some common basis for research, as well as information management, share data, that's where we're going to get a huge amount of LMIC data by having centers that have some collaboration and coordination in how they gather data. Now, there's just some of the groups we worked with. There's a couple more things here. The recognition, again, is quite recent in the medical end that the militaries are usually the ones with the resources, and that's clearly true here in Pakistan for major disasters. Interesting quote, but there's probably a lot of truth to that. And I'll just quickly run through these. There was a program just started in the US a couple of years ago by Donald Berwick and some people in the Air Force. Sorry, this didn't come through, but the bottom line, and this was a publication in 1991, they recommended bringing the civilian and military resources together and basically taking the trauma center system and uniting it with the military. This is just showing a timeline of this civilian trauma research. And this would point out the fact that, at least in the US, that line you see is the line of optimal use of resources. And the things that have a red box around them above the line are getting more research money than really benefits society as a whole. And if you're below, you're getting less. And you can see traumas there. And this probably shows it a little more clearly for stroke and injuries. We really should be spending more money on research. And that's probably true in developing countries, even more so than in developed countries. So in the US, about a quarter of medical research in the military is for trauma, which is a lot higher than in the civilian side. And so this is this project that's ongoing now. It's not because of the bureaucracy in the US, it's not moving very fast to bring together civilian and military. I'll just quickly go through a couple of their findings so far. Half of the deaths of people under 46 is due to trauma. This is in the US, a huge cost. And it's interesting at the bottom there, where one lives may determine whether one lives after trauma. In this map of the US, the red shows where the high incidence of death from trauma occurs. The blue is where you're within an hour of a trauma center. And so if you're in a car accident in Manhattan and you're in a car accident in Montana, the odds of dying in Montana are probably tenfold greater than in Manhattan just because you're that much further from help. And this was an interesting finding, really supports that notion. They had a directive during the Afghan conflict just a few years ago saying, we want to get every injured military person to help, to a medical help within 60 minutes. And they actually went down from 90 minutes to 43 minutes. And the case fatality rate went in half as well. So it says, we may talk about a golden 4 hours, but every minute counts. And so the more you can integrate all these things and have them happen automatically, the more people you're going to save. This is just showing that, yeah, you can learn a lot in the civilian sector from the military as regard to hemorrhage control, et cetera. This is the big thing that, in civilian sector, trauma is pretty much a constant volume. In the military sector, if you're not fighting a war, these guys are doing what I did for several years. We're flying around maintaining your certification, but you're not doing any good. So if you can bring that in, they could be utilized around the clock. Similarly, when we were in Chile, we met last month with the director of the Naval Hospital, and Sergio Aguilera is there now, said, hey, unfortunately, this hospital is not very busy. And so we really need to augment our volume. And that's where you can bring them together with a civilian center. And apparently they do some of that, quite a bit of that here already. There's a lot of things I think here in Peshawar they could export to other countries to show optimal utilization of the military resource. But this is just to show that the sort of care that these hospitals are giving in the US is really quite similar to the civilian hospitals. And we're not fighting wars, so it's not a lot of war trauma. That's just the structure, and this was just a summary of that report. And this is the structure, trying to bring those two things together. And we're kind of proposing the same thing eventually on an international basis. And just a summary of that, and I'll say I'll talk this afternoon. We'll continue on that. But I just wanted to really thank Tariq. Has been he's really done an incredible amount here in Peshawar, and it's really a model for other countries that want to take their healthcare from next to nothing to first class. Well, anyway, thank you.